I rarely talk about what I say I will talk about. So I'll try to be true to the title. But I think the most important thing that I want to talk about is, politically speaking, I think all the research and all the work that's being done is highly significant and highly important. But it's political. It's to make these medicines legal. What I'm interested in is the experience in therapy of using psychedelics, especially today I'll talk about LSD. And what I'm going to say, I think, has implications to the future. Suppose there comes a time when these substances become legal. Just as Torsten said, you have to be very careful who the therapist is going to be. MAPS is thinking about a therapist training program. But I think the skill of a psychedelic therapist can only be transmitted through apprenticeship. It's a very, very complex task to actually be there with someone who is in an altered state of consciousness. The possibility of alienation, the possibility of making things worse is enormous. So the gains are high, but the dangers are also great. And I think the only way to make sure that in the future, when these substances will be legal, they will not cause harm, is to focus not on the drug itself, but on the relationship between the therapist and the patient. So there are no tricks, there are no theories, and there are no steps to follow. The simplest thing, which is widely accepted, that, for example, during an LSD session, there ought to be music. And there are experts today who will tell you exactly what kind of music to play at the beginning of a session, in the middle of a session, at the end of a session. I think all that is just one-upmanship. It's creating a new elite. It's increasing transference rather than getting rid of transference. Transference being presuming that the other knows. From the time we are little, we presume that our parents know, and we hang on to that. So transference, even in adults, is basically hoping that there is someone who knows. I don't know, but the other knows. Freud said that the end of transference is when the patient realizes that he or she also knows. Jacques Lacan said Freud didn't have the courage to think this one through. Because Lacan said the end of transference is when you realize nobody knows. So that's the spirit in which one has to step into the therapy situation, whether there is LSD involved or not. So the therapy is more important than the LSD. The relationship between the patient and the therapist is more important than the substance that they use. In fact, it could even be used, LSD could be used to avoid the difficulties of human relationship. Triangulation is usually a word describing when the patient and the therapist are too frightened to actually relate to each other, and they pick a third thing to attend to, and then they don't have to have a relationship. They talk about tennis, or they talk about baseball, or even the psychedelic substance can be an excuse not to have a human relationship. My teacher, my major teacher was R.D. Lang, a Scottish psychiatrist who called himself an interpersonal social phenomenologist. Phenomenologist means that you basically, all you have is your experience, nothing else. Everything else is hearsay. Interpersonal means that the trouble is never within a person, it's always between us. I do believe that anything that is in the DSM, the Diagnostic Statistical Manual, all the varieties, all the different flowers of madness and disturbing behavior and states of mind are really varieties of post-traumatic stress disorder. That is, I don't think anybody goes crazy who hasn't been hurt. So already the original trouble is already between us. So it has to be resolved between us. One of my teachers said, only you can do it, and you can't do it alone. And that is true in my experience. Lang diagnosed our society psychophobic. And basically he said, we are afraid of our souls becoming alive. So we are psychophobic. Now, if you take LSD, your soul becomes alive. So it could be a terrifying experience both to who is attending and to yourself and to everyone else around. How to prevent it? He says, real health is characterized by the realization of the fact that all is one, that all is in each, as each is in all. So if you take that seriously and not just spiritualize it, but leave it on the psychological level, because if you go to spirit too fast, you miss out on the psyche. And then you have to deal with it later. So what does that mean? It means that one of the goals of psychotherapy, I would say, is emancipation. That a deep experiential realization that nobody is above me, nobody is below me, we are all on the same level. Emancipation, man in emancipation, is hand, manus. An emancipated person is someone who holds himself or herself in their own hands. And that means that once you're emancipated, you are not going to allow anyone to speak down to you, and you are not going to speak down to anyone. You realize an essential oneness, that everything that in some way we are one. Now, any masculine approach, I think, is mistaken. The heroic approach to go in and help someone is doomed to failure, I think. Sooner or later, somebody will have to pay for it. I think, just like with birth, and LSD has been called a birth drug because it allows you to regress all the way to birth or even conception or God knows how far back. So I think that the feminine approach is far more appropriate than the masculine approach. The ethics of the situation, I would say, is maternal ethics. The feelings and the whole scenario is very much that of allowing, letting be, dealing with whatever emerges. And this is the point where the therapist has to be in a very special state of mind and not wanting to control what's going to happen. And that's scary, to do it by the seat of your pants always, as if for the first time. Because the moment you have expectations, you're already limiting the situation. Anyways, without psychedelics, we flow in and through each other. There are no individuals. In the early LSD experiments in Saskatchewan, in Canada, where I'm from, they did group LSD sessions where a dozen people would take fairly large dose of LSD and locked themselves up for 24 hours. One of the people who participated in such an event told me that near the beginning, all 12 of them suddenly were turning to the wall, not towards each other. And they were all moaning and groaning. And everyone was feeling nauseated and bad. So somebody said, will someone go out and vomit? Another person stood up, went out to vomit. Everyone felt better. So whatever state of mind the therapist is in will deeply influence the state of consciousness that the patient is going to dare to get into. I'm going to read you something that in 1904, Rainer Maria Rilke wrote when he was 28 years old. He says, we must accept our reality as vastly as we possibly can. Everything, even the unprecedented, must be possible within it. This is the end, the only kind of, this is in the end, the only kind of courage that is required of us. The courage to face the strangest, most unusual, most inexplicable experiences that can beset us. If we are not open, if we don't have this courage, nothing happens. Now, there is a whole other clinical observation which was forced on me just through sheer practice. And that was during the very early times, say birth plus or minus 9 months, there is a phenomenon that in the literature, some people use the French term participation mystique, the mystery of participation. People have noticed that the mother and the baby partake in each other's consciousness and unconscious. It's like they swim in each other. Now, if during that time the mother doesn't naturally adapt to the baby's needs, the baby will be deeply, deeply traumatized. It's a feeling of, I say naturally, it's not blaming the mother. The mother may be in a situation where she's distracted. And if the mother is distracted, then the baby is precipitated in a do or die moment of almost like you drop a baby, the baby goes, oh my God. Now that's the response to the mother frustrating the baby before the baby's capacity for frustration reached the level at which the mother is frustrating the baby. Okay, so you can tell very quickly in psychotherapy whether that's an issue for someone or not. Because, I'll exaggerate, for someone who this is a problem to, will come in, if the blinds are down, we'll open the blinds. If the blinds are open, we'll close the blinds. We'll rearrange the furniture. We'll make a request for water or something else. Immediately, the therapist is tested as to his willingness or her willingness to adapt to the patient. Any demand on the patient to adapt to the therapist is deeply resented. Now imagine that a drug like LSD, which by its very nature regresses you, the only approach, any kind of heroic, paternal approach, basically any pressure on the patient, whatever way, is going to prevent the patient from becoming authentic. There is no drug, there is no state of consciousness where one cannot lie, where one doesn't feel what is expected. Sándor Ferenczi, one of the to me, more sympathetic Hungarian psychoanalyst said, you need only 2 qualifications to be a good therapist. You have to have 0 ambition and a lot of time. Well, I say that that's precisely what a psychedelic therapist needs. 0 ambition and a lot of time. Because the moment the patient feels that it's the therapist who is driving the session, the whole session is derailed. It's absolutely essential that the therapist follows the patient rather than the other way around. Any therapeutic zeal can do untold harm. So let me give you an example. One of the scientific questions that arises in psychedelic therapy is, how do you select your patients? How should we select? What are the selection criteria? Well, I'll tell you, there isn't any. Self-selection, I would say, is probably the best criterion. I have never suggested to anybody to do an LSD session. I only respond to people who say, I'm going to do one. So self-selection. Because anything else, any other restriction, basically shows the therapist's fear because his or she has to cover his or her ass. But otherwise, what's going to happen is totally unknown. I'll just give you, I think I have time, 2 little stories where I would say most people would have refused to be associated with. One was a roughly 50-year-old woman, very depressed. She was in a mental hospital when there were still mental hospitals in Vancouver. And she was in locked ward. She received several courses of ECT, and she was on major antipsychotics. And she attempted suicide 4 times. When her psychologist at the hospital, who was a patient of mine, for some odd reason thought that she could benefit from seeing me. So it's the psychologist who transported this woman to see me twice a week for 50-minute sessions. And for 3 long months, this woman came in, sat down, didn't move a muscle, never looked at me, and just sat there. 3 months, twice a week. Who am I to say anything to her? I thought at first. I welcome her, and there is it. After a while, I began to notice that I'm thinking things that I probably wouldn't be thinking if I were alone, if I wasn't in her presence. Now, those thoughts which I thought arose because I was with her, I started to verbalize. I even joked that she's my analyst because she's quiet and I'm speaking. She didn't crack a smile. Cut a long story short, her first words to me were, after 3 months, and totally surprised me because by then I expected that she'd never speak. She said, I'm afraid of you. I said, what could I possibly do that would be harmful to you? She says, you might take my freedom away from me. I said, how? She said, I'm afraid I won't feel free to commit suicide if I continue this. I didn't think that was such a bad thing. So that's how it began. We had regular, I mean, nothing is really regular, but unassisted psychotherapy for about 3 years, during which time she was a pharmacist by trade. Basically what we came to was that she lived in a 24/7 soap opera. From the time she was born, she wanted to be the good child of her parents, then the good student at school, then the good wife to her husband, Then she said she didn't want any children, but her husband did. So then she had to be the good mother to her children. And she was very keenly aware that no one was interested in her. Everybody was interested in the mother, in the daughter, in the pharmacist. So I had to make her very sure that I didn't expect her to be a good patient. It would have been one more load on her shoulders. Clearly, her attempts at suicide were to escape the 24/7 soap opera. I mean, imagine yourself having to perform 24/7 and there is no way out except you off yourself. I could understand. Only alternative I could offer her was, maybe there is a way to be authentic and not have to play anything or anybody without killing yourself. I wasn't sure, but at least it seemed to me worth trying before she really offs herself. So during the 3 years, she weaned herself off all medication. And then she had the bright idea that she's going to take LSD. I said, wow. Okay. You tell me when, I'll come over. That covers me legally because, you know, she, ever since, for the last, how many years? 48 years, I have attended people who have ingested psychoactive substances basically to protect them from freaking out. So I still do that. Okay, so first session, absolutely nothing happens. She gets even gloomier than ever before. A month later, she says, I'm doing it again. I say, okay. Worse, she cries. She has a horrendous experience of abandonment. She sees me walking away from her. She says, all I see is your back, and you're leaving. Now that opens something up. That opened up a trauma that she didn't talk about before. She was 3 years old, stationed, her family was stationed in Germany, and they got the order to go back to Canada, and her parents suddenly thought, wow, we haven't even seen Europe. So she was 3 years old. They put her with a German nanny. Basically, her words were, they parked her like luggage. And the older children and the parents went off for a 6-week tour of Europe. Of course, the German woman who looked after her didn't want any cries, didn't want any tears. So basically, from that moment on, she felt she was a piece of shit because gold you take with you, shit you leave behind. So she got the message. So she thought I would leave her sooner or later. That's why it was a very traumatic LSD session. So a month later, I thought she's going to kill herself for sure. It was clear between us that suicide prevention wasn't my job. And it was clear even between her husband and me that if he wants to protect her, then he has to have a 24-hour vigil. I can't do that. There was the third LSD trip, and guess what? She came out smiling and laughing. She came out, you know, the Groff 4 stages of birth, bliss inside, no exit, bloody battle, bliss outside. She came out in bliss outside, and she conceived a way of being where she didn't have to play any roles. And she wasn't too frightened that her husband won't have anything to do with her, her children won't have anything to do with her, because that was her fear, that unless she performs the roles, nothing going. Now that was 10 years ago, and she's still perfectly well. She's living a very creative and happy life. She performs occasionally grandmother functions now, which she used to dread. but now she embraces it because she is in control of it. She doesn't play the grandmother, she is the grandmother. That was that. Once a year she sends me a little note, love you and hate you. Okay, now one more quick one where I think selection criteria would dissuade most people. I worked for at least 4 years with a woman who would be diagnosed, I don't diagnose, multiple personality disorder. When she first revealed, she was about a 55-year-old woman who suddenly turned into a 7-year-old boy in my presence. I thought she was pulling my leg. Around that time I was going around saying that multiple personality disorder was iatrogenic. Patients just performed that to entertain their therapist. But it wasn't so. So I wanted to look up the literature on what to do with somebody who is so split. And then I resisted the urge, and I thought, she's gonna teach me. Her multiple personality disorder is not like anyone else's. So that's how we went. The little boy taught me everything. The little boy knew everything. He was the repository of all the memories of torture and sexual abuse that she went through in her childhood. She knew nothing about the boy. Occasionally she would come in as the woman, she would say hello, the boy would come out, and at the end of the session she would come and write a check and sign it and says, what did we do? But of course, when I offered to tape record the session, she would have none of it. So it took a while, and magically they integrated. Physiologically, there were some very interesting things. She wore very strong glasses. When the boy came, the boy took the glasses off, and he had perfect vision. She was allergic to peanut butter. The boy could polish off half a bottle of peanut butter and show no symptoms. If she had a cold and she took aspirins, he called me up and said she's over-medicating him. After he disappeared, because she was slowly able to receive all the information that he was the depository of, she had to change her glasses, which was half as strong as it was originally. After that, for about 5 years, she was fine and lived her life and worked. And then she calls me up and says she's going to do some LSD. I thought, what if the boy comes out again? But that was my worry, not hers. I mentioned it to her, but she said, well, then we'll deal with him. The reason was that she thought that her life was a little bit gray, not enough color in it. She wanted to, she felt that some creativity in her could be loosened up, that there was still some fear. Again, cut the long story short, had a very deep LSD session. What she later considered life-changing was, at a certain point she was crying and there was snot and tears all over her face. And just without thinking, I had a handkerchief and I wiped her nose. And she said nobody has ever done that to her. Then she felt the grief of never having been cared for, never having been loved. It's the smallest things that can make the biggest difference, and it cannot be programmed. It somehow has to happen. One has to allow for it. Whenever in a session, either the person herself or himself wanted music programmed, never got to it. Silence seems to be much more important during an LSD session than music. The music, I think, is for the sake of the therapist. It keeps you the expert. when I actually mentioned that, how about if you have to have music, don't you program the music, ask the person to bring their music, or if you do it in their home, let them select what they want to listen to. Well, the answer was something like, but most people we work with have such poor musical education that they wouldn't know what to bring. Well, I don't think that is true. So, one more thing I want to bring up, which is, if you really want emancipation to occur, and this is really a taboo topic, but I think it's time to mention it. I think the LSD healing session is different if the therapist also takes the medicine. I mean, that's obvious, but I have to say it because nobody talks about it. If I go into my therapist and the therapist is cold sober, I might fear that he or she is just observing me. There's no participation. I mean, we are not. If the therapist is also in an altered state of consciousness, then the trust that can be had. I said everything is post-traumatic stress disorder. The major symptom of post-traumatic stress disorder is I don't trust anyone. Judith Lewis Herman in Trauma and Recovery says the first phase is to reestablish some measure of safety, security, and trust, and that takes as long as it takes. With some people it takes an hour, with some people it takes 5 years. Now, if both the therapist and the patient ingest LSD, it's okay if the therapist has half the amount of the patient. It doesn't have to be totally equal, because after all, the therapist has the role of having a container, of containing the patient. The patient has no responsibility for containing the therapist. Then there are these very human moments where the patient looks into your eyes, the therapist's eyes, and says, are you for real? What are you going to say? I mean, if you say yes, it won't matter. That's not going to persuade anybody of anything. So there are issues of shame. There are issues of trust. There are issues of betrayal that I think only come to surface when the therapist risks everything. I'll close with telling you a little story about Hungarian shamans. Hungarian shamans know when a new shaman is being born. They mark the kid, they don't tell even the mother, but they follow the child. And when the child reaches a certain age, they grab the kid, take him or her into the forest, usually him, and in the forest they debone the person. They take every bone out of his body and take him apart, and they put him together again. And after they put him together, there are several bones left over. So if there's one bone left over, he's a one-bone shaman. If 5 bones are left over, he's a 5-bone shaman. And what that means is that, say, a 3-bone shaman has only 3 real healings that he can do, no more, no less. Because every time he does a healing, a bone is used up. So you can't just do this day in, day out. You have to be very, very mindful who you are going to risk your bone for. And when you do the healing, a family member of yours dies. So there is an enormous sacrifice the healer has to make for a real healing. Now, this is a fairy tale, but I actually want to leave you with it because I think it's true. So that explains why most shamans are thought of being tricksters. If I can trick you into healing, I'll trick you. I'll save my bones and my family members to when really nothing else works. Thank you very much.